we thought we'd start with some basic definitions. Some of this will be familiar for some of you in the audience, and but maybe not familiar to all. And we definitely look forward to any comments you have or other ways, other ideas you have about defining gender at the end of this presentation. So gender is a core social characteristic. It's often expressed or seen in terms of the social roles that in each society, the roles that are defined for men, women, and people of other genders, but also the relations between them. So how people are, how their roles and responsibilities are defined, but also how they interact between them. And that's specific to each society and can change over time as well. But it defines their roles, their responsibilities, and also their rights and aspirations. So an example of this in health systems, obviously, if we look at the history of the professions, is that nursing was originally framed as a profession that emphasized nurturing or caring and was purposely kept separate from the curative powers of medicine, which were male-dominated. Obviously, this has changed over time, but we still see nursing as a profession that's primarily made up by women. And I think it's something that it's still an important part of the makeup of nursing as a profession, but obviously with task shifting, nursing is also beginning to take on, in some countries, the role of nurse practitioners. They're actually moved beyond that traditional framing of their profession. At the household level, another way in which gender plays a huge role is that in many ways for care seeking, men are often the key decision makers at the household level. So a lot of our health promotion messages might target women as carers of young children or in terms of addressing women's health, maternal health, but actually miss that men and other senior members of households might actually have more of a role in terms of decision making. Yet they might actually be not as well informed or may not see pregnancy, women's health, or some aspects of childcare as their responsibility. So I think work in gender is to try and change some of those norms and look at what are better ways, more equitable ways of organizing society. As I mentioned, gender operates at various levels. We tend to focus more at the interpersonal relationships, and I think we saw this in the Rings photo competition. There was a lot in terms of looking at gender as a social determinant. We tend to look at gender in the realm of care seeking, but obviously gender also has a role more broadly in how society is organized and affects how the social norms, but also the allocation of resources and how institutions, rules are set up that govern our society. And in that sense, they really affect how communities are made up and structured, how service delivery systems operate, and how economies are organized. So undertaking a gender analysis means not only looking at individuals and at the household level, but more broadly. For example, I think it's Sheo in Tanzania, looked at community-based planning for primary health care. And so despite legislation that has encouraged community input into planning for primary health care, they really found huge barriers by gender and level of education for community members to input into planning at community level in contrast to health professionals. And so we can look at it at different points of the health system, how gender dynamics operate and how they link with other aspects of social determinants. I think another important consideration for gender is that it's not static. Although their gender inequalities are pervasive, they're actually quite dynamic and malleable. And we've seen, for instance, gender norms and relations change quite dramatically from generation to generation. And in that sense, they change and they really can work in multiple ways. They can reflect current power hierarchies, or they can also subvert power relations, depending on how people engage with their social context. And I think within the context of Rebuild, we're examining how gender operates in conflict-affected regions. Sorry, that should say affected rather than afflicted. Obviously, how men and women are affected by conflict varies quite dramatically, with huge mortality implications for men, but also how programs are organized in refugee camps and who accesses those services have implications by gender. At the same time, we've seen, for instance, in the context of Afghanistan, there are also huge opportunities for change. And so, for instance, with the recreation of the midwifery program in Afghanistan, there are ways in which countries recovering from conflict can also lead to quite dramatic decisions in terms of opening up opportunities and changing gender norms. There are other huge structural changes that are undergoing in society, for instance, with the role of innovation, how mobile phones are used, and how that changes people's access to information and decision-making. And we've seen in the context, for instance, in the Sundarbans in India, migration is a huge factor in terms of changing how households function, communities are organized, and that has potential implications for gender. It can be both positive, neutral, or negative, and I think that's why we need research to better understand these dynamics. Ultimately, what we want to emphasize is that how people respond to gender really matters. So how they absorb, reflect upon, and respond to gender norms varies, and that gives us opportunities to better understand, but also work with programs that affirm equality. What do we do once our findings are disaggregated by sex? We need to look at whether those differentials are equitable or not. And doing that means looking at the context. And there are two ways in which following a context-embedded approach is important. One is we really believe in rings that if we really want gender analysis to be owned, it really needs to start at the level of local actors. We need to work in distinct contexts and really work with how people on the ground understand gender issues, for them to be able to understand them but also own and come up with their own innovations on how to apply gender analysis to make it relevant to their own context. So I'm going to use an example here based on the work that our Makerere within Future Health Systems has undertaken, reflecting on their own work of working on vouchers to improve access to services for maternal health. And it asks, through a series of 4 questions, looking at their findings but also going a little bit further, working with local actors. They did this with participatory research and began to ask some basic questions in terms of who has what, who has access to different resources, who does what in terms of what are the roles, the division of labor, looking at decision making, who decides on things, and also finally who is valued for what. And it changed the way they looked at their intervention. So they had a very successful pilot and an ongoing intervention that is looking at using vouchers to improve women's access to services. And they saw dramatic increases in access to services. So a very successful initiative in many ways. But once they looked more closely at that, they saw that while access to services increased, it wasn't clear always. Women were not that much more clear about their entitlements or necessarily why they were, what aspects of antenatal care and delivery care they should be accessing, or not much more aware of their entitlements. And underneath that, women were still dependent on men for savings. Further analysis looking at what were the roles, how did the voucher system change the division of labor or what people's involvement was, we found that the vouchers really incentivized male drivers, the boda drivers who got vouchers to take women to services. And there were some positive unintended consequences in that sense. They were the ones who really followed up women to ensure that they returned for care, and in some places also made sure that women got more prompt care by jumping the line in facilities and advocating for women. Decision-making in terms of who decides, although the role of male drivers increased, decision-making for maternal health was still within the hands of men and mother-in-laws within the house. And there was some discussion in communities whether it was appropriate that male drivers were now more involved than fathers themselves in terms of their wives' health care. And ultimately, the underlying at a broader level, women were still valued for having children, but their health during pregnancy was not valued as much. And when women accessed services, their own views on delivery and the positions in which they should deliver, that they should labor in and have childbirth in, were not often respected by health workers, and they reported a lot of rude behavior or unkind behavior, as well as problems in terms of unofficial fees, a lot of treatment that made them not that enthused about returning to healthcare services. Another way in which we're really pushing the boundaries of gender analysis is intersectionality. And that's a very big term, but it simply means that we recognize that gender doesn't function on its own. It doesn't exist in its own social vacuum. It really works dynamically with other forms of inequality. And that means how it interfaces with age, poverty, literacy, geography, disability, and sexuality, just to mention a few, really has implications for what gender means at the local level in different contexts. So one example, which comes from the work in the Sundarbans, but is also true in many other contexts, is that younger women tend to have less agency over decision-making at the household level, over their own health and over children's health, than older women. And the pervasive power, for instance, of mother-in-laws over younger women is a good example that not all women, even in families, have the same level of agency and autonomy. Particularly in India, also parity matters a lot, and whether you're the mother of male children rather than female children really changes your status in households. My own work in Tanzania has begun to look at, in the new, in a pilot in Morogoro that launched a CHW program that focuses on promoting awareness on maternal and child health, the CHWs that were younger men who were better educated, in some sense, really looked at this opportunity to advance their work in community health, but they had much less credibility amongst the community than women who had older women who might have been less literate and therefore fit the guidelines of the government program less, but had more credibility. It's very hard for a young man to talk to an older woman when he hasn't had children himself, and there were a lot of issues of talking about reproductive health issues to an older woman if you're a younger man. And I think programs need to consider how they tackle those kind of gender issues at the community level. We also saw, for example, programs, guidelines that encouraged male participation in antenatal care, and particularly for HIV testing, often disadvantaged groups of women who might not have a male partner that they could bring to antenatal care. And they were discriminated against because women who came without their partners or women who didn't have partners were sent to the back of the line, and that that's an unintended negative consequence. So what we have here is a definition. We really value ethics analysis because it means analyzing empirically and theoretically the ethical dimensions of the research cycle, actors, and processes in health systems research with a focus on relationships, including power relations and social exclusion. For us in particular, we wanted to focus on the ethics of power relations and social exclusion because we felt that health systems researchers, policymakers, and practitioners can work together and benefit by strengthening justice and equity in two particular ways. We wanted to look at how these different actors work together to focus on the role of power. So looking at their own specific positions and their own looking at across disciplinary areas to look at developing and conducting studies and communicating research findings with all these different stakeholders, but with a key focus on the role of power. We also want to, in particular, look at innovative research approaches and how do we strengthen guidelines and review processes for these innovative research approaches, primarily action research and quality improvement cycles. These are increasingly used in health system studies, but might have specific needs or might have specific issues when it comes up to ethics analysis that needs further attention. So we know that health systems research is primarily often reviewed by institutional and national science and ethics committees from a biomedical perspective, which tends to be more codified but is less grounded in the different contexts that health systems come alive in and may not pay as much attention to gendered social relations than the social sciences. And Adnan Haider and Bridget Pratt and others have really begun to recently look at recent frameworks that look at facilitating the planning and review of health systems research, and they've called for further conceptual and empirical work on health systems research ethics. We'd like to contribute to those efforts by looking more closely at social relationships. So for instance, we've found a common experience is that health providers and community members and research managers, issues come up in terms of observing unethical behavior on a routine basis. And what we mean by this is, for instance, when you're working together in action research, you often find on a routine basis, unfortunately, issues of illegal charging practices, examples of very poor quality of care, very poor treatment of patients as they come into services, illicit sales of drugs, or actions of corruption. So the dilemma is when you're working in a partnership when you're trying to create a partnership between researchers, providers, and community members, how do you share this information that you come across with? How do you share the information so that it supports a systemic positive change rather than a backlash or scapegoating? We know that health systems operate through power relations, so how information shared really operates in certain ways. So we want to balance the rights to confidentiality of diverse participants, and we want to make sure that certain voices that are often excluded from policy and practice debates are heard. And we want to change these unequal power relations rather than transform or rather than exacerbate them. I know in my instance, for instance, working in India a long time ago, feeding back information from a community audit of maternal health, it was easy for the district health officer to sort of then blame the lower level health worker. And we want to make sure that when we share information, people don't go back to their hierarchical ways of functioning. Another example is, for instance, often as researchers on the ground working in partnership with health providers and managers and community members, we're often asked to request to assist with providing vehicles for management activities or supporting a community organization. So the dilemmas are, is our own scientific learning undermined by changing what we're studying, by actively intervening in the situation? How sustainable is this help over the long term? Are there potential longer-term solutions being undermined by helping? And are unrealistic expectations raised? And it really looks at what is the right and responsibility of researchers vis-a-vis communities and providers, and how are these relationships changed, and what are the long-term consequences of that?